My name is Brian Wallace. Hello and welcome to the Season 2, Episode 49 of the Physician Assistant Exam Review Podcast. This week we're going to be continuing with dermatology and covering skin cancers. All right, welcome aboard, welcome back. I'm glad that you found the show. I've had a ton of fun producing it. You can find all the notes over on the website, www.physicianassistantexamreview.com. That's where I keep all the notes. Everything that I do is basically sent through that hub. This podcast is one of the things that I do, certainly, and it's a big part of what I do, and it's one thing that people find me through and find to be really helpful. But it's not the only thing I do by any means. You can find all the notes from the shows over on the website. You can find a place to sign up for the email list, which is where I drive home all the tips, tricks, and techniques for improving your studying, improving your test-taking ability. All that stuff is driven directly through the email list. And also, all the special offers and things that I do sort of extra come through that email list. So what did I do? A couple weeks ago, I did a sale on The Final Step, the book that I wrote, the 1,200 questions on short, punchy questions that cover key terms and are incredibly valuable for your exams. That is, you can find on the website, but also I ran a special sale on that, like a month ago, and offered that at a reduced rate that you will not find on the podcast. You'll only find that through the email list. Last month, I ran a giveaway of over $900 worth of study material, things that I use to get ready for my PANRE. And again, all of that driven through the email. So definitely, one, the content's great, and it's really my favorite thing driving me. But the second part of it is that's where you're going to find out the more timely information. If you're looking for more, then that's definitely the place you want to go. Unfortunately, the person who won the giveaway didn't respond, so now I've got to draw somebody else today. So hopefully I'll be shooting out that email later on today to get it out to someone who checks their email address. So definitely, if you signed up for that, pay attention. You should be, if you won, you'll be getting an email today, and hopefully I'll be able to notify everybody about the winner shortly, as long as that all turns out the way that I hoped that it would the first time. But, sometimes it just doesn't work that way. So this week, we're going to be covering skin cancers. We're going to be moving through dermatology. We're almost done. This, I think we'll wrap it up in the next episode with episode number 50. I think we'll wrap up dermatology. We just have a couple of little details to get to. But today we're going to be covering skin cancers, and it's pretty straightforward stuff. It's not super complicated. The one part that is difficult is how differentiating the different skin cancers, especially on an exam, not necessarily in the office, but on an exam by their descriptions, can be a little bit tricky. Not too bad. There's only two, I think, that are tough to mix up. And we'll get through that, and we'll explain exactly what I mean by that as we move through. So anyway, let's just go ahead and get started then and move forward with our priming questions. Name the skin cancer associated with AIDS. Name the skin cancer associated with AIDS. What color are the lesions of Kaposi sarcoma? What color are the lesions of Kaposi sarcoma? What is the most common skin cancer? What is the most common skin cancer? And what is the most deadly skin cancer? What's the one that we need to be most concerned about? All right, we'll get to those at the end. See if you can listen along and pick out the answers to those. If you didn't already know them, definitely pay attention as we move through, and I will share them with you as we continue. So we're going to start with Kaposi sarcoma. This is a systemic disease caused by herpes virus 8. I doubt you'll need to know that for your exam. Most often, the lesions are on the skin surface, although they can be found other places. But you're going to pick them up initially on the skin surface. We'll get to some of the other issues in a minute. Typically, they're a very slow developing illness, but in conjunction, where it became famous was with AIDS. In conjunction with the AIDS virus, it progresses very quickly. And in the early 1980s, it became linked directly to the AIDS virus, and that's why we see this. Usually the immune system is strong enough to fight this off, but in the case of an immunodeficiency, then we have some struggles, and we'll talk about that a little bit as we move forward. The clinical presentation here is typically the skin lesions. They are flat or raised, and they are purple. So you get these purple skin lesions. They may be widespread or found in only one area of the body. I always thought they were all over the place, but that's not necessarily the way it works. You can get these, as I said earlier, usually we see them on the skin surface, but you can get them in the GI tract, so people can have present with difficulty swallowing or weight loss because they can't eat. You can get pulmonary lesions where people would have, and these sort of make sense for pulmonary symptoms, they'd have difficulty breathing, there'd be a cough associated with it, chest pain, and then they can even get hemoptysis. Labs and studies, you're going to need a tissue biopsy for diagnosis here. And as far as treatment goes, there is no cure, right? There's no way to clear this. It's if your immune system doesn't do it on its own, there's not a lot we can do to help it. The main issue, what you want to do is treat the immunodeficiency. The reason why the person is experiencing this in the first place is because their immune system can't fight it off. So one thing they found is that the lesions begin to shrink even after the first antiretroviral therapy for AIDS patients. So it's important for Kaposi sarcoma to treat the underlying issue, that immunodeficiency. Now, you can do local treatment like radiation or cryotherapy, but it's not going to be effective. If you think about the way that this works, it's kind of a widespread disease. So if you treat one or two lesions, or you try to it's just too much to treat unless it's in a very limited area. So if you have a small area of skin involvement, like we said, it can be either widespread or in a small area. So if it's in a small area, then yes, you could treat it locally. But in general, that's not going to do a whole lot of good. So that's Kaposi sarcoma. Again, what are you going to need to know there? They're purple lesions, can be found all over the place and associated with AIDS or immunodeficiency. Next, we're going to talk about basal cell carcinoma, and this is the one that I am most familiar with from my practice. Remember, I don't talk about it as much as I used to. I do multi-special surgery at a small community hospital. So I help in all kinds of different departments. Subspecialties. So I'll do orthopedic surgery. I do C-sections. I do GYN. I do some urology. I do some ENT. We do plastics. So we do a whole bunch of different things. And as far as skin cancer goes, basal cells are the most common thing that I see. Actually, it's just the reconstruction after. So basal cells are the most common skin cancer. So that's something worth noting. The most common skin cancer. And these are considered malignant because they're so locally destructive, but they don't metastasize. They don't move through the body, but in the area that they're in, they will cause a lot of damage. Clinical presentation is a single lesion described as raised. The sort of the key term that goes along with basal cell is that shiny or pearly edges. And then that lesion is usually ulcerated as well. And one of the problems with these is there are many different presentations. And this is going to be the same with all the skin cancers as we go through. That's why a biopsy is going to be important. They can have an appearance similar to eczema or an acne scar, or all kinds of just different things that make it really hard to tell. These are found most commonly in sun-exposed areas of the skin, like the ears, nose, and face. But surprising to me as I read through this, about up to a third are found in non-sun-exposed areas. So just because you find a lesion on somebody's back or something doesn't mean that it's not a basal cell. Okay, so you definitely want to be aware of that. So we'll talk about it here as well. So how are you going to differentiate this one in a test question? Even let's just say from Kaposi sarcoma, you get these shiny, pearly edged lesions. You get an ulcerated lesion. We didn't talk about ulcers with Kaposi sarcoma. We talked about a purple, flat, raised lesion, right, in multiple areas. Well, our basal cell is only going to be a single lesion, right? So that's immediately how we can tell those apart. Now, I don't think they're going to give you those two lesions to tell apart, and if they do, that'd be fantastic because it's pretty easy in a test question. But just I want you to start thinking along those lines. Labs and studies. Clinical diagnosis is going to get you started, but you're going to need a biopsy to confirm this. Treatment is going to be Mohs surgery. So how this works is usually a dermatologist will do surgical removal of the tumor, of the lesion, and do a microscopic examination of the borders and attempt to get clean margins. From that point, usually one of two things happens in the office. They either get clean margins or they don't. And then they'll need a wider surgical excision than you could do in an office. They wind up going into an operating room to get that taken care of. And then depending on the size of the lesion and how much tissue was removed, this is where I come in, as I usually am called in with a team for plastics to close these incisions. And actually with an ENT, actually they do ENT facial plastics, so I guess it's all plastics. We'll go ahead and close these. And it doesn't sound like a big deal, except these can get pretty nasty. They can grow pretty big. I did one not too long ago where the mass was on it behind an ear, and it wound up picking up probably, when we started, the wound was probably 6 to 8 centimeters in diameter, maybe a little bigger. And the dermatologist still hadn't gotten clean margins, so we had to continue further out than that. So the wound wound up being pretty large, and to get that closed, you weren't going to do that in an office setting. In fact, it was quite difficult to do even in an operating room setting. But thankfully, we were able to do it. Unfortunately, I don't get a lot of follow-up with my position. I don't see the patients in the office. I just see them in the operating room. So I can't tell you for sure that wound up healing nicely, but it was a big wound that we wound up closing. And that's, again, where I come into this, is we close these wounds after the surgical excision, after that Mohs surgery. And usually that will take care of the problem, especially with a basal cell. Remember, they don't metastasize. There's just the local destructive capabilities of a basal cell. All right, squamous cell carcinomas. Let's talk about these for a second. So we're going to talk about specifically squamous skin carcinoma. You can get squamous cell carcinoma in lots of different places. So we're going to, obviously for dermatology, we're just going to narrow this down to the dermatology section. And this is the second most common skin cancer that is found. Basal cell, again, being the first. It occurs primarily in sun-exposed areas, and it's often malignant. So how people present with this is a growing, non-healing, rough, bumpy, scaly patch, right? So that's a little hard to remember too, because all these kind of sound the same. So it's a growing, non-healing, rough, bumpy, scaly patch. So basically you have a non-healing lesion in a sun-exposed area, and you need to be worried about it. You need to be thinking squamous cell carcinoma. Sorry, I'm just updating my notes on something I screwed up. So these lesions have a variable appearance. So it's really, again, it's difficult for them in a test question to explain to you what these look like, how they function differently from, and separating them out, right? So these have a variable appearance. They can be non-healing, rough, bumpy, scaly patch, which doesn't give you a whole lot of information. They're going to have to give you more, right, in order for you to tell them apart. And that's why things like pearly borders really makes a difference, or ulcerated lesion. Those types of things are, unfortunately, I know that they're trying to get, everyone tells me they're trying to get away from key terms, but you can't. You have to separate these somehow. You have to separate basal cell carcinoma from squamous cell carcinoma, or even better, hopefully you won't see these two in the same question, right? As two answers on the same page. Hopefully you'll see, melanoma, basal cell, and Kaposi's in the same, because to me, squamous cell and basal cell in a test question are hard to tell apart. Okay, again, they're usually sun-exposed areas. They're 90% found on the head and neck for squamous cell. You're going to, and again, what you do with them is similar also. You're going to do a skin biopsy in order to diagnose this. And then treatment is going to be pretty similar. You're going to, you're going to look for things. You're going to try to do prevention, right? Because it's a sun issue. So you're going to use skincare. You're going to use sunblock. You're going to use hats. You're going to try to stay out of the sun, all that stuff, just like we would for basal cell. And then we're going to move on to Mohs surgery. And then chemotherapy and radiation can be used if necessary. So that's if it goes on to be metastatic. But it's hard to tell those apart. It's not going to be super easy on your exam to get a description of those. That's going to be separated. So just remember, basal cell is the more common one, locally destructive. Squamous cell is just a little less common, variable appearance, both found in sun-exposed areas. And squamous cell can be metastatic. Our last one for today is going to be melanoma. This is a malignant tumor made up of melanocytes, those pigmented skin cells. This is far less common than basal cell, but causes up to 75% of deaths from skin cancer. So this is the one that we need to be the most concerned about, even though it's less common. In our clinical presentation, lesions are most commonly found on sun-exposed surfaces, so same as everything else. That doesn't really help us. And one thing we always want to watch out for, and this is the thing that you hear about, is changes in shape, size, or color of an existing mole or a new mole. Those are the things to be where these sort of will show up on physical exam. So mole characteristics, which are going to help us to pick melanoma out of a crowd. And it's not the greatest acronym, but you get A, B, C, D, E, E, F, G as far as things to look for. But to me, these are helpful, but I think you can remember this without the silly acronym. Let me run through it and then we'll discuss it a little bit more. So A is for asymmetry, so it's not a nice round circle. B is for borders are irregular. C is for color changes. D is for diameter greater than 6 millimeters. E is for evolving over time. The second E is for elevated above the skin. F is for firm, and G is for growing. Now, to me, I don't know, spending time memorizing this as the A, B, C, D, E, E, F, G of melanoma does not make a lot of sense. To me, thinking about the picture of melanoma in my head and understanding that it's a mole that's gone crazy, right? So you get these weird borders, you get changes in color. It may be growing above the skin, and then it's a growth, right? So you get to the firm, and growing is kind of goes hand in hand with that. So to me, they're not going to ask you for these 6 things, right? They're going to ask you they're going to give you a lesion that has some of these characteristics in the question and ask you to tell it apart from basal cell, basically. That should be the kind of thing that they want you to do. So it's a single lesion here, but it's a deformed mole is essentially, or a new mole that is kind of deformed is what you're looking for. So this to me is where these acronyms can be more trouble than they're worth. Just understand that it's a mole gone haywire. Labs and studies, you're going to biopsy, and tumor thickness is the most important part of predicting survival rates. So the deeper that melanoma goes, the bigger a problem it is. And then you can do a CT or PET scan for malignancies. Treatment, again, prevention is key. Sun protection. You're going to want to use sunblock and get out of the sun, basically. If you do wind up diagnosing this, it's going to be surgical excision. And then we're not going to go into, there's a whole staging and things for this. We're not going to get into that as far as your exam goes here. I don't think it makes a lot of sense. But part of that surgical incision may also be sentinel lymph node biopsies to see the extent of the disease, radiation, and then chemotherapy, depending on where we are at as far as this goes. But again, all that is well beyond the scope of this review and of your studying. So that'll wrap us up for skin cancers for today. The next thing I want to talk about is our study tip for today. But I do want you to, before we jump into that, is just to understand, I want to keep pushing the ideas of how to separate these diagnoses on exams, how to separate the ideas in your head when you see these test questions. So our study tip for today is going to be to do a little bit each day. Not what I don't like to see is and what I know does not work well is when people go to the library and spend 6 or 8 hours on a Saturday and bang through a ton of material. It just doesn't work. And it's something I discussed a lot in the last issue of the Physician Assistant Exam Scholars newsletter, which is the monthly newsletter I send out with, again, just a deeper discussion into some of these ideas to really help you grow as a student, as a test taker, as a learner, as a practitioner. And in that, I talked a little bit about how doing a little each day has a much greater impact than doing something all at once. So you can think about learning these topics just like going to the gym, or something else I just started doing was a yoga practice. And the teacher keeps going on about, and I really like it because he keeps talking about how you haven't stretched in maybe decades, which is probably true in my case, and you expect to loosen up all in one day. And he recommends against pushing really hard and just sort of easing into things and seeing how it goes over the coming weeks, not trying to see how much you can get done today as far as that practice goes. And it really, I think it's the right mindset for that class for me, absolutely. But I think for studying, it's the same idea. You can't show up once, go through a ton of material and expect to remember. It's got to be a little bit each day. It's got to be reviewed each day. It's got to be gone over each day so that it stays on the top of your mind. It's another reason why I do the newsletter, is because if I just wrote a book and you read that and you finished it, you would say, oh man, these are some great ideas. This really makes a lot of sense. And you'd put the book down and you'd be done with it. And you'd probably never see it again. What I like about the format of a monthly newsletter, although I get why it's a struggle for me to write. I get why it's a struggle for you guys to read and go through. But to me, it touches on those bases of repeating key ideas, things that seemed far-fetched and different from how you did things initially. But if you hear them brought to light in a couple different ways over time, they start to filter into your consciousness and start to be something you can use routinely. And the more touch points you have on something like that, the better off you are, the more you'll get out of it, instead of just reading something once and it disappears, just like studying for one good day. That's great, and you can feel really smart at the end of that day, but a week later, you're not going to retain any of it. So it's to study a little bit each and every day, to put the time in each day, to review a little each day. Even if we're talking about 10, 15 minutes, that's definitely a much better way to go. All right, so let's answer our priming questions. Let's see if you can remember any of these from our, since we just covered it seconds ago. Name the skin cancer associated with AIDS. Name the skin cancer associated with AIDS. Kaposi sarcoma. And putting these back to back should have made it really easy for you. What color are the lesions of Kaposi sarcoma? Purple. That one should be pretty easy as well. What's the most common skin cancer? The most common skin cancer is basal cell carcinoma. What's the most deadly skin cancer? That's melanoma. And one of the things I think, and I used to link to pictures, and I tried to find some, but it's tough to get paid pictures of the different types of diseases here. So I found some great ones of basal cell that I could buy and put on the website for, but I couldn't find melanoma or squamous cell. So to just put the one wouldn't really help to compare them. And I really don't like to steal them from other places and put them on my website. I just think that's a poor practice. So I've gotten away from putting images up on the website, and I used to do it. I used to link to images, but the problem is all those links break. Everybody changes their sites around, so I can't keep up with it. It's just become very cumbersome. So I've taken down most of that, but it's so easy for you to search now, but that you don't really need me to have it up on my site. If you just type in some different images for comparing basal cell to melanoma, comparing basal cell to squamous cell carcinoma, comparing it to Kaposi sarcoma, looking at those images is going to make a huge difference for you. So once you've listened to this episode, maybe jot down the notes about the key factors, the important points of telling them apart, and then pull up the images and see how you can make those stick in your head a little bit better. I think that makes the most sense. All right, so we're going to wrap it up for today. Again, I think we've got one more episode for dermatology coming up. That would be episode 50. Looking forward to wrapping up term and moving on. One thing I did note before I hopped on here was that in iTunes, we're up to 795 reviews, which is amazing over the years. So I'd love to get that over the 800 mark. So if you haven't left a review yet, good, bad, or either way, go ahead and drop one in over there. It's a little cumbersome to get them in, but I do appreciate those, and I read every one, absolutely. And again, at 795, I'm like, geez, we're so close to 800. I'd love to push over that mark. So anyway, thank you so much for listening and tuning in. Really appreciate you guys showing up. Ooh, that's not the right sound. I told you a couple weeks ago I got a new soundboard. I haven't quite worked it out yet. There we go. That's a little better. Okay, so we'll let the music take us out. Thank you so much for tuning in. Definitely go over to the website, hop on the email list. That's where you're going to get the most information about what's new, what's coming out, and what I'm up to and how the community is functioning. So definitely go check that out. Thank you so much for tuning in. And anybody taking their exam this week, good luck to you. And I look forward to hearing about your success. Take care.